Gives me a great pleasure to introduce our next speaker, which is Professor Peter Lim from Gleneagles Hospital in Singapore. Professor Lim is well known in the field of men's health as a pioneer who is ever dynamic and always pushing the new boundaries of technology and therapeutics. So he's the right man to give us a talk today on the new therapeutics for erectile dysfunction. Professor, please go ahead.
Thank you, Chairman, Co-Chairman, ladies and gentlemen. Now, my talk today is what are the new therapies across the horizon concerning erectile dysfunction. Now, if you look from this, we know that there's a need for further research for newer therapies after the era of the launch of the PDE5 inhibitor. What else do we have after this? We have the oral dissolving PDE5 that's going to be launched next a couple of months in Singapore. What else do we have? We really have nothing. Now, the only direction you can go is towards developing cell and gene therapy or tissue engineering. If you want to look at the complete list, this will be the complete list. Unfortunately, most of these are only the pipe dream. It's not going to be of practical utilization, not yet anyway, for quite a number of years to come. Now, what is reality? The reality and the only real deal we have today is the advent of the shock therapy. Now, can we shock Johnny down under back to life? Now, this technology started with a rather enterprising fellow in Israel, and he devised the concept that we can actually apply shock waves to the penile shaft and restore erectile function. He proposed that if we were to use low-intensity shock wave, we can cause angiogenesis. But the shock wave that you apply should be of a very low intensity of about 0.09 millijoules per square millimeter. And this energy is only a fraction, you will note, of the type of shock wave that you and I know we use to treat renal stones. Now, this is a shock head that's used in this new technology. Now, what does it do? It can be used to treat mild to moderate erectile dysfunction. And in my hands in particular, I've noticed it is particularly very useful to convert PDE5 non-responders to responder with this technology. Now, how the bloody hell does this thing work? Well, basically, the shearing stress causes responses at the endothelial lining of your penile tissue. It liberates nitric oxide at that point and stimulate growth factors to cause angiogenesis. Now, for the critics, is this real or unreal? Yes, it is real because the literature, if you search through it, we have all the evidence for the mechanisms I've just outlined to you. Now, as I said before, mind you, this is low-intensity shock wave. The high intensity of 450 bar started with shock waves for the kidney stone. Then orthopedics came in for pain, and the energy dropped to 200 bar. Now, our cardiac boys were smart, actually. They were there before us, and they dropped the energy to 80 to 100 bar, and they shocked the heart to cause the coronary blood vessels to revascularize. And now finally, if we drop ourselves down to 80 or lower, we are now finally arriving with this technology for urological problems of erectile dysfunction. Now, this is a cardiac machine and how it works for the coronary vessels. And this is the setup for shocking the heart. And if you look at the angiogram before and after for the heart, even to the unbeliever sitting there, you see that new blood vessels have regrown. Now, Yadi in Israel came up with this technique when he produced his first paper showing that if he were to shock the penis, and in his series, he compared it with shocking the forearm blood vessels, and he demonstrated that you had flow-mediated dilatation was improved in the penis, but not in the forearm with the technology. Now, in his first series, he showed that the IIEF, the QEQ, the rigid score, and the SEA-RQ were all improved after shocking the penile tissue. In this series that he came up with, blinded comparison, he showed that in these 60 patients, indeed, the results were incontestable. And if he included a segment who had PDE5 before, and then they were no longer working with PDE5, and when given the shockwave, they responded. Can you see that? Before treatment and after treatment, with the erection hardness score improving to 3 or higher after the therapy, as you can see from the pie diagram. Now, how is this applied in the clinic? So it's very simple. You just apply it to the side of the penile shaft.
It's non-invasive and pain-free, with no sedation or anesthesia required. With proven success in promoting cardiac angiogenesis as well as extracorporeal shockwave therapy for treatments in the field of urology, Metaspec now applies the same expertise to vascular-related erectile dysfunction with the ED1000. Applied to the penile shaft and crura, the ED1000's low-intensity shockwaves result in improved blood flow and accumulation of blood in the penile corpora following sexual arousal.
You don't need to take this machine. There are currently now 4 other machines in the market, but this was the original machine, and that's the one I'm using.
3 treatment locations to which 300 shocks must be applied. Above the base, at the center of the shaft, and right below the glans penis. Place the center of the shockwave applicator below the patient's anterior superior iliac spine in the direction of the pubic symphysis, following the corpus cavernosum's crura direction. Apply shockwaves according to the treatment protocol. Then repeat the procedure on the opposite side of the pelvis.
Now you apply the shockwave at 5 points. 1, 2, 3, 4, and 5 at the crust. This is the protocol which I use. Week 1, 2 sessions. Week 2, 2 sessions. And another 2 sessions in the 3rd week, followed by a 3-week period of rest for the revascularization to occur. In the original protocol, a 12-week session was advocated, and we have found that this was not necessary in about 80% of patients. If you are going to do the 12-week protocol, you wait for this rest period before you resume another 3-week period of treatment. And basically, that's how it's done. The patient is very comfortable. He's talking to me or reading a book, and there's no pain. And you can hear the banging in the background. Now, what are the clinical studies that show you whether this technology works or cannot work? Now, look at this study of 90 patients. And the authors used the Rosen's point response to evaluate their series. Increasing by 2 points, improvement, mild, by 5 points for the moderate category, and 7 points for the severe category. And if you look at this meta-analysis of the erectile hardness score, again, in about 100 patients, EHS improving to grade 3 or 4. In this number, after 6 sessions and 12 sessions in addition, if you want those who failed to respond within the first 6 sessions. Now, I'd like to go over the second session strategy again. Now, if you look at this series of 24 poor responders, 6 proceeded to a 12 treatment session, and you can up the response rate. So if you had only a 33.3% initially with the 6 sessions, you can improve it to about 58% response after you repeat it. But this is not in the majority of patients that require this. What about the technology? Is it durable, or is it only a brief period of improvement? Well, if you look at this 1-year follow-up, you'll realize that the result has been sustainable and was durable. And newer papers today show that they were still working at 2 years. Now, if you do an objective assessment and you measure the peak systolic velocity, you can see that after the treatment, the peak systolic velocity in the penile arteries have improved dramatically. Now, the current international users are listed on this chart, and this list is getting larger. The highest number of patients that have been done are actually found in India. And I think the record number treated is about 750. Now, I report herewith for your attention my results from May to December last year of 145 patients treated for erectile dysfunction. You'll see that these are the success patients, and if they only stay or improve to EHS 1 or 2, I consider them as failures. And we have a response rate of about 84%. Now, if you look at this series of 145 patients, you realize that if you fall within the age of 50 to 70, and I believe the majority of you are in this category in the audience, except for Stephen Lim, who's forever 16, then you are admirably suitable for this therapy. But in my hands, and I think my other colleagues have indicated, that the minute you reach beyond 70, it seems to have a lower response rate. And I have observed this to be so. Now, why is it the younger ones are also not doing well? These are young diabetics, type 1. The younger you are with erectile dysfunction, you have serious disease. With serious disease, we have to do serious technology and therapy to treat you too. Now, what about the failures? Well, these are the failures. They somewhat echo the age range of the previous slide, and I don't think any meaningful data can be obtained from this. But I did find that if you notice that if you are non-diabetic, you seem to do much better. Also, if you did not have serious coronary vascular disease or ischemic heart disease, you also seem to do much better. Now, the hypertensives also, you notice if you have serious hypertension, you do less well. And in particular, if you have got high lipids, also you don't do so well. Now, you look at testosterone. Now, what I did was, those people who are hypogonadal and I gave them testosterone at the time I started therapy and brought this level up. I found that if you treat them with testosterone brought up to a normal level, it also gave me better results. Now, this is a very important slide because in many of my patients, most of them that come to you and request this treatment will be those who have tried all the PDE5s in the marketplace. And the non-responders in this series of about 90, you can note that they have responded after the therapy. And that echoes other reports by other authors. Now, if I put them together, even my patients who were naive to PDE5 inhibitors and those who had it before and now no longer getting a good erection, you will note that indeed the non-responder now becomes the responder. Glaringly so when you put them side by side. Now, if you take the whole series, I've discovered one thing, that if you want to get good results, if you take the whole lot together and put them together, and I put them on chronic administration of a low-dose PDE5 inhibitor. And here, of course, there's only one in the market called tadalafil, 5 milligrams. Notice that this is the result of the patients who were put on chronic low-dose PDE5 inhibitor. And this was the group that had no chronic PDE5 inhibitor. And now if I put them together, lo and behold, note that the use of concomitant low-dose PDE5 inhibitor done pari passu with the treatment process gives much better results. And my colleague in India and elsewhere have shared with me, they see the same phenomenon. Now, I'd like to refer to you the paper of all papers for today. This is the paper by Dr. Vasson, which was published in the Canadian Journal of Urology, February 2015. Now, notice that he showed a placebo-controlled study and the results in this paper. He had 135 patients, 95 had ESWT, 40 had sham therapy. The head made the noise, but he put in a metal plate to block the shock waves going into the penis. I don't know how he managed to get this approved. But you notice that he had a 90% success rate. Patients reaching EHS 3 and 4 at 3 months follow-up. But he noted that at the 4th month, the success rate dropped a little. He used a 12-session protocol with an in-between 3-week rest period. This was because this was the original study he did when this machine was launched. And he finally got it published, and that's the paper. So ladies and gentlemen, Mr. Chairman, Mr. Co-Chairman, and learned colleagues, I submit to you that this technology is a very interesting new addition to our armamentarium. It is indeed indicated for arteriogenic ED. However, reading of the arteriogenic disease is useful for us to predict the response and report to the patient before starting. Milder arterial disease and younger patients, I note, and others have noted, they do much better. The PDE5 users post-treatment, for the PDE5 users, after treatment, they could take it off. Or to maintain functionality, they could be maintained on a very low dose of oral medication, like 2.5 milligrams of tadalafil. In treating these patients with this technology, I note that the patients get more confidence with their sexual life. However, I also note in those very bad patients with severe coronary and penile artery occlusive disease, vascular disease, the response can be dismal. there is a possible role, I think, in this technology to alter the primary pathology. Hence, it may have preventive or a role, and it may slow the progression of arterial disease or other disease states in the penis, in addition to its therapeutic role. I strongly believe that further studies are needed on how we can optimize the effect of our shockwave therapy. I submit to you that there must be a role with continued use of PD5 inhibitor. I also think, if you look at the literature on use of stem cells in restoring penile function, that if you were to combine these two, they may get much better results. And finally, growth factors, if injected into the penis in new studies done by us in the future, may actually translate into more durable results with this technology. Thank you very much, ladies and gentlemen.
Thank you, Professor Peter. So, any question from the floor, please?
Peter, congratulations on a very nice series. Well done. I wanted to know at what stage do your patients improved? Tells you they're improving. At what weeks or months?
Okay. When you are doing the shockwave, at every session you grade the response. My personal experience is that most of them do not show a response until you reach about the third or fourth session. The good responders will begin to show improvement already. Generally, you see improvement at the end of your 6 sessions. However, a word of caution, I always tell the patient that you need that 3-week waiting period for the revascularization to be fully effective.
Yeah,
so I do the final assessment at the end of the 3-week waiting period.
So how do you explain why you see some initial improvement in the erection?
The initial response is, I think, contingent on the primary status of the vasculogenic ED when you first admit the patient into the therapy. The bad patients, those with severe coronary artery disease, those who are very old, above 70, those are the ones that don't seem to show a good response. The younger patients seem to show this earlier response, which can be seen as early as after the 3rd or 4th session.
So I presume your first line of treatment is still PD5 for when your patients come to see you, rather than this treatment, is that right? Your first line of treatment.
All patients that see me are not admitted into this study initially.
So it's the
I always tell them that the first line treatment for erectile dysfunction goes along to the tried and tested pathway. So we give them everything except this, which is reserved for to me, best for the non-responders. But I included some patients who were naive, basically to see whether there was a better a response to patients who were actually virgin to PD5 inhibitors.
And Professor Lim, how you score the success by EHS or any other scale?
Okay, in the paper by Dr. Varson, what he did was he did all he applied all the instruments of assessment of ED on the patients. He also used the classical IEF, QEQ, and so forth. But if you read this paper and read other people's paper, the best way of assessing it is the EHS score. So for me, I relied very heavily on this because I think it is the mother of all scoring systems, because you actually see it. You see it during your performance of the procedure also. So when you're doing it, you actually see the erection if it happens, and you can assess that it's improving and the hardness was getting better. And then at the end of the treatment, you finally make your final scoring.
And is it painful, the treatment? It's noisy, it's okay, but is it painful?
Now, there are about 4 other machines in the marketplace.
Yeah.
And if you put your hand there and try it out, and there are some in the exhibition area, you'll find that this particular model did not give much or any pain of any mention that the patients said to me. There are other models that give you a bit more pain, actually, real pain. But this one did not give pain. And this particular model had the greatest exposure to patient care since it came out.
Peter, the Chinese patients usually have a smaller penis compared with the Westerners, and the head of your treatment, the head is quite big. Is there any point in causing an artificial erection and see what the results are like? Is there any point, and whether it helps or makes things worse?
I don't think you need to do that, because when you're doing it, actually, the minute it's beginning to respond, you can actually get an erection during the therapy. And indeed, I will report to you at a future meeting another technique which has modified. Note that I showed you that cartoon where the therapy is applied at the tip, at the mid shaft, at the base, and at the right and left crura. Now, I've now come up with a new strategy to apply a continuous application along the entire length of the deep cavernosal artery. So during the therapy, I will go from the right and left crust, move it all the way to the tip of the penis along the pathway of the deep cavernosal artery, and continue doing this throughout the therapy. And I believe, and this is just my hypothesis, that I will come up with a better endpoint than the other investigators.
Okay, if there's no other questions, in the interest of time, we will conclude the session. Thank you. Thank you, Prof. Lee.